And now we have come to the last lesson 4 in this Obstetric Emergencies Part 1 series. I'm still Anna Nolte, and in this lesson we are going to talk about shoulder dystocia. Now again, shoulder dystocia is, as we will come to just now, means that the shoulders of the baby is stuck, the baby's head's been delivered normally, and the rest of the body can't be delivered because the shoulders are stuck. And that obviously makes it an emergency that again you have to be able to deal with. Again, not something that you can practice over and over till you know how to do it, but something that you have to have the knowledge on how to do it. So this is very important. And unfortunately, shoulder dystocias can happen there are some risk factors which we will come to now, but and it can also unexpectedly happen in any other normal delivery, and suddenly you have a shoulder dystocia. So this is one of the emergencies which is, like all the others, very, very important to be able to deal with. Now, what happens in the case of a shoulder dystocia? As I've said, it's not always predictable. There are some risk factors which we will come to just now, but in many of the cases, it just happens. What happens is that the fetal head becomes delivered normally, and then this anterior shoulder is being stuck here behind the symphysis pubis. And this anterior-posterior diameter of the shoulders are just too big to move through this part of the pelvis, and that's how we get that the fetus is being we get a shoulder dystocia. And we as I've said, we get that the anterior shoulder gets caught here behind the symphysis pubis, and the posterior shoulder sits here in the sacrum of the pelvis, and it's very difficult to come out. Now, the consequences and why it is such an emergency is that the mother risks physical trauma in the sense, but because of all this interventions and maneuvers, that she can suffer from vaginal or cervical lacerations, or she can get bladder atony because the bladder sits right in front of the symphysis pubis, and again, because of all the manipulations and to get the shoulders out, the bladder might be injured. We get postpartum hemorrhage is a possibility because the uterus is not contracting well enough, again because of all the possible manipulations. Psychological stress, because again the mother knows that something is going on, something is wrong, she stresses about the prognosis of her fetus, etc. And then, as we've said, vaginal and cervical lacerations, we get very easily third and fourth degree tears, specifically if there was an episiotomy being done that has torn further, or in the case where the perineum is just tearing. Now, what can also go wrong in the baby is that we have here that there's a lot of nerves coming here from the cervical part of the spinal cord that's going to the arm of the fetus, and in this stretching and all kinds of manipulation, we get that this nerves might get injured, and we have a very common injury which we call the brachial plexus injury, which causes eventual paralysis of the baby's arm. What we also get is that there's a compression of the neck and the central venous system, because the chest part of the baby is now being compressed in the pelvis, and that makes also that there's a reduced placental intervillous flow, and that causes fetal hypoxia. So we also get that there's not enough oxygen going to the fetus, which makes that there's fetal compromise. And then also because of the pressure here on in the intrathoracic area, because this is now being pressed into the pelvis, we also get that there's not enough filling of the fetal heart, there's not good enough blood circulation. Now, as I've said, there are some risk factors which enable us to kind of predict in some cases where shoulder dystocia might happen. Also, but as I've said previously, in many cases, it might happen unpredictably where we're not able to predict it. So the risk factors is where we have a history of a previous shoulder dystocia, and that unfortunately tends to happen again, specifically when the previous babies were also bigger babies, which we will come to just now. In the case of maternal obesity and excessive weight gain, there's a higher incidence of shoulder dystocia. Also in macrosomia, where the babies are bigger than 4,000 grams, so 4 kilograms. And this is one of a very big risk for shoulder dystocia. And it goes together also with gestational diabetes, where we know that often in the case of gestational diabetes, and specifically where the diabetes was not well controlled, we get very big babies, that there's high incidence of shoulder dystocia. Then in the case of post-term babies, tend to be bigger than term babies, and that also increases the possibility of shoulder dystocia. Then in the case of the fetal factors, as I've said, macrosomia, where the baby is big, is one of the biggest possible reasons for shoulder dystocia. Now, how do we diagnose shoulder dystocia? How do we know it's shoulder dystocia? Now, first of all, the baby's head is being born up to the head's been crowned, and then the rest of the head and the face struggles to come out. The face and the chin are birthed slowly or with difficulty, and we call it this typical classic turtle sign. The head comes out up to a certain point and doesn't come out further. So the head's been born, and then it retracts a little bit back, tightly against the maternal perineum after delivery, and this makes it a little bit more difficult to manage the whole shoulder dystocia, because there's very little space because of this, the fact that the head sits right on the perineum, and there's not lots of space for us to intervene, makes the management of the situation very difficult. We get that the chin draws into the perineum, and the cheek sits tightly against the vulva. Restitution of the head does not take place spontaneously, and then gradually we get that the fetal head is become cyanotic, and we can see the face is getting bluer and bluer. And also because of this, a lot of blood that's now collecting literally in the fetal head, we also eventually get small petechiae forming on the fetal face, and we often see that on the faces of babies that's been born with a shoulder dystocia. And then the final way how we diagnose this shoulder dystocia is when we try and deliver the shoulders, and we're just not successful. We don't make any progress in delivering the shoulders. Now, the important principle here is, remember we've said the shoulder dystocia has been caused by the shoulder being stuck behind the symphysis pubis. So we want to try and increase the size of the bony pelvis as much as possible to get that shoulders to go through the pelvis. Now we know that that's not very possible during any time, because the pelvis, there's not a lot of movement in the pelvis. But we also know that during pregnancy that there is a little bit of a relaxation of the joints in the pelvis. So there are possibilities that we can use here, which we will come to just now. We need to decrease the biacromial diameter of the fetus, so the diameter between the shoulders we have to make as small as possible, and we need to rotate the fetus. If you can remember the diagram that I've shown you and said the anterior posterior measurement of the shoulders is just too big to get through the pelvis, so we have to make that smaller. Now, what is in our efforts to do this, the very important aspects that we need to remember is to never pull or rotate the fetal head. There are maneuvers where we try and rotate the shoulders, but we don't try and rotate the fetal head, because that just makes the possibility and the incidence of the nerve injuries just too big. And together with that, also to avoid downward traction and jerking movements, because again, your incidence or possibility or danger to injure the brachial plexus is just too big. And then very, very, very important, that fundal pressure should never be used. Remember, if you visualize the diagram which we showed you, which is the cause of shoulder dystocia, we said that the anterior shoulder has been stuck behind the symphysis pubis. So if we apply fundal pressure, we just put more pressure on that shoulder that's been stuck above the symphysis pubis. So fundal pressure is not going to help at all. So it should never, ever, ever been used. And if it's been used together with pulling on the fetal head, we get a high incidence of brachial plexus injury and also uterine rupture because of this pressure on the uterus, and we can also get the detachment of the placenta if the placenta sits in the fundal part of the uterus. So fundal pressure under absolutely no circumstances. So what do? First of all, we place the patient on the edge of the bed. That just gives us a little bit more maneuverability, space to do certain maneuvers, space to get in. We communicate with our patient. We tell her what's going on because, as we've said, she knows something is going wrong and she's very worried about the condition of a baby, whether he's going to be alive or not. And then all the following of the intervention should now happen simultaneously. And as we've said, hypoxia is one of our big problems, so we have to act quite quickly. Now, the first very important thing is what we call McRoberts maneuver. It's just been found out by McRoberts. It's a guy that this maneuver has been named after. And what we do is we pull the patient's we flex the patient's knees and pull it up as near as close as possible to her chest. So we almost cause hyperflexion of these knees on the patient's chest. And what it happens is, you can see on this diagram, it just causes this sacrum to move a little bit more backwards and the symphysis pubis to move a little bit more upwards, and that just this tilting of the pelvis makes that this diameter might just increase with millimeters, and very often it's only a millimeter or two that we need space for the shoulders to be dislodged behind the symphysis pubis. Then the second very important thing is, while we are doing the McRoberts movement of the knees, we also apply suprapubic pressure, not fundal pressure, but suprapubic pressure. We press just above the symphysis pubis, and we can do it like you can see here with our fist, but also with the heels of our hands, because that helps us to apply the biggest pressure. And we should apply the pressure from above, so we should get on the bed with the patient and apply the pressure so that we can apply as much as possible and try and dislodge the shoulder here behind the symphysis pubis. And as I've said, under no circumstances any fundal pressure. Then we try to deliver either the anterior shoulder or the posterior shoulder first, And on the YouTube video that I'm going to show you, you will see how it works. We again, if I've said that because the head is so stuck on the perineum, that space is quite a problem. So we can consider doing an episiotomy just to make some more room for our maneuvers. Then we apply firm pressure on the fetal head, and we try to deliver the shoulders as we normally do by firm downwards pressure on the fetal head and trying to dislodge the anterior shoulder. Obviously, if that doesn't work, please do not pull or tug on the fetal head, because then you cause brachial plexus injuries. Or we can try and deliver the posterior shoulder first by putting our fingers, as you can see on this diagram, by putting our fingers here in the occiput of the baby. We go into the posterior, behind the posterior or in front of the posterior shoulder. We can put our fingers here in the elbow part of the arm, and try and split and get the arm out and pull the arm out. And the moment that this posterior arm is being born, you can immediately see there's much more space there, and then we can just sweep the anterior shoulder out and have it been born as well. If that's not working, if the classical interventions up to here is not working, what we can also try and do is to deliver the posterior shoulder by threading a catheter between the shoulder and the posterior arm, and in that way kind of pull the arm out, more or less in a similar way as I've shown you on the previous slide that we do with our fingers. We just have a little bit more of a maneuverability if we use a catheter here to pull the arm out. Or we can also turn the patient on an all-fours position like we see here, and in this process, also by relieving the pressure on the sacral area, we again make it possible for the sacrum part to move up a little bit, and for the symphysis pubis to move a little bit forwards and up, and that just increases the diameters of the pelvis a little bit, and that might dislodge the shoulder. Another possibility that also works very well is to put the mother on the bed in a squatting position, and we get exactly the same little bit of increase in the pelvic size, and in the squatting position and in all fours, we also almost have a kind of a Roberts maneuver again that helps to increase the size of the pelvis. So if we look at the acronym for the management of shoulder dystocia, we look at what we call MAPS. M stands for McRoberts, and together with McRoberts, we have the suprapubic pressure. Then we have the delivery of the anterior shoulder, and if that doesn't work, we deliver the posterior shoulder first, and then we have salvage. If neither any of these things help, we can put the patient in an all-fours position, or we can put her in a squatting position, or we can thread the catheter through the posterior arm axilla and pull the arm out. Then on the next slide, there's a little bit of a YouTube video that you can also look at on how to manage the shoulder dystocia. And then we have come to the end of this whole series of obstetric emergencies, and you have to complete your quiz to end and make sure that you get your certificate at the end of this part of the series.